Due to time limit, we need to start our this session. And this session, we are be honorable to invite Professor J.B. Hong come to our society and give us a special lecture. And I just should briefly introduce my brother, my friend, and also my mentor, Professor J.B. Hong. Actually, he from United States or Chile, and then he went to South Korea and entered in Yonsei University, and after the training, and also got a PhD degree in Yonsei University, and then been recruited to the Asan Medical Center. Asan Medical Center is huge and the biggest medical center in South Korea. And so he working there and established the very important microsurgery team in Asan Medical Center, plastic surgery. And his reconstructive field is so outstanding. More than 300 papers published in the world, and also numerous awards and visiting professorship. It's hard to just show briefly introduce him. So it's a long story, and as he's enthusiastic and also very active in the world, so he go around all the countries in. I think if you count on the earth, maybe per year 2 circles. So it's the set. So he also got numerous awards. The most important also. One is the Cortina Lecture Award that is recognized by the American Society for Reconstructive Microsurgery. And he also served as a pioneer in sport microsurgery, his field, and also most focused in low extremity reconstruction. And in lipoedema field also, numerous publication and outstanding finding. And today he will give us a talk talking about lipoedema surgery and another new field in this topic. We'll be talking about the shockwave treatment in lipoedema. So please, Professor J.T. Hong, and thank you, Tom, and just not doing too much today. So, thanks.
It's great to be back in Taiwan, and also so nice to see so many friends. Back in the year 2000, it was my first time in Taiwan, and I visited Changgun Hospital. And back then, I worked with Dr. Fu Chan-wei, Professor Chi-Eun Lin, Hu Chi-chen, David Zhuang, many of the pioneers in our field. And hopefully, we will all carry on their legacy. And this is, based on that beginning, I guess I was able to take the research a little bit more. And today I'm focusing a lot on lower extremity, as Yuren said. And today I'll be sharing some of the new insights on lymphedema surgery. So lymphedema problem is not new. Everybody thinks lymphedema is a recent problem because of cancer, but the truth is lymphedema has been around more than 5,000 years, since the ages of the pharaoh. So the lymphatic system is in a way a system of immunology. And in our body, the vein and the artery is responsible for 80%, but 20% of our body fluid is being circulated by the lymphatic system. So if you think about what is lymphedema, lymphedema is a break in balance between formation or accumulation and then the clearance capacity. So if the clearance capacity goes down because they remove a lymph node, or there's obstruction in the pathway because of inflammation, then the accumulation happens. And this is what lymphedema is all about, in a nutshell. So what happens? So what happens is, okay, everybody finish, let's go. Coffee break. If you're able to solve the problem or not, I don't know, but hopefully. But you know, if you give a microphone to a Korean, there's two things that they'll do. Either sing. Oh, okay, back. Thank you so much. So, so what happens is that if the fluid accumulates too much, it starts to excrete, and it starts to excrete, and a lot of the skin problems happen. Excellent. Thank you, Shishir. So this is what happens if the fluid accumulates in our body because the lymphatic fluid is not able to circulate. Then it will find a way to excrete. And this is what we see, the fluid becomes excreting in the skin. And this is why it's also a problem for the wound healers. Because a lot of the time, when you're seeing these kind of wounds and seeing clear fluid come out, it's because of lymphedema. And this is why I want to share how can we improve the problems related to these kind of lymphedema. So even a long time ago, they started to think about how can we improve the symptoms. And they start to think, if we excise the skin, if we remove the skin, then maybe the lymphedema will get better. And this is still a very important part of surgery today. However, I want to focus my talk today on the physiologic surgical approach. And this is basically the lymphatic system. And the lymphatic system travels in our body, and ultimately it drains in the subclavian vein. So the lymphatic system travels like the veins and the arteries, and ultimately what happens is that it drains to the vein. So the lymphatic system ultimately drains to the vein, and this is very important. So the first thing when we think about lymphedema is we have to ask, where is the obstruction? What is causing the lymphatic fluid to accumulate? Here, this child is a 3-year-old child, and he had a congenital kidney agenesis, so that he was born without a kidney. So they were doing hemodialysis, and they used the hemodialysis through the subclavian vein, and they were using it so many times that the subclavian vein actually got injured. And the problem with the subclavian vein being injured is that the lymphatics couldn't drain to the vein. So what happened is it started to accumulate in the lungs, and it caused chylothorax. So what did we do? So ultimately, what we did was we did a LVA, lymphovenous shunting. So we created an artificial shunting. So the lymphatics can drain to the vein before draining to the subclavian vein. And you can see that we're able to solve this problem of chylothorax within a month after providing an extra shunt. So the key question in lymphedema is, where is the obstruction? How can we correct the pathophysiology and ultimately increase the quality of life? So that's the question, and that's the role of microsurgeons, plastic surgeons today. So the basic physiologic solutions we have is creating a lymphovenous shunt other than the subclavian somewhere in our body. So that's called lymphovenous anastomosis. And also, we're finding out an easier way of surgery, which is called the lymph node to vein anastomosis. And finally, if they take out a lymph node in cancer, put back the lymph node by doing a free flap. So these are the three basic modalities of approach. Then, is this something new? There's nothing ever new, because this same kind of thinking was already being applied in 1960 by the O'Brien group. And they tried to connect the lymphatics to the vein. But it didn't work. Why it didn't work? Because once the lymphatics is obstructed, it undergoes degeneration. The lymphatics go degeneration, and the lymphatics doesn't work. But back then in the 60s and the 70s, they did not have the capability to know whether or not the lymphatics is functioning or not. So the biggest innovation that I think in my mind for the lymphedema surgery is the preoperative imaging capabilities. So there's many imaging technologies. There's scintigraphy, ICG, and the ultrasound, but they're all limitations. So the more you do is actually better. This was a study that we published. What is the best way to detect functional lymphatics? And in our hands, it's not the ICG, it's not the MR lymphangial, but a new modality called ultra-high frequency ultrasound. And I think that is the best way to detect functioning lymphatics as we reported here in this case. So why is there a limitation? So let's take a look at this video here. So everybody knows about the ICG. The ICG, once you see the ICG, we know that the lymphatics is functioning. Here's a patient with a relatively early lymphedema. So you can see that the ICG is clear. So there is lymphatics. However, the limitation of the ICG is that it is only able to penetrate 1.5 centimeters. So anything beyond 1.5 is not visualized in the ICG. This is an ultrasound, and you can see the ultrasound is actually able to see lymphatics and the vein. So let's take a look at this patient here, a little bit more advanced, but the ICG, you don't see anything. You do not see anything. So in the past, when we did not see anything with the ICG, we used to say, there's no lymphatics. But it's not true, because the limit, again, of the imaging is only 1.5 centimeters. However, in the patients with advanced lymphedema, we find that 8% of these patients, they don't have good functioning lymphatics. And this is actually proved by showing that there is no lymphatics with the ultrasound. But 92% of the time, even if you do not see a clear lymphatics in the ICG, as you see here, Starless pattern, with the ultrasound, in 92% of the time, we'll be able to find a functioning lymphatics and a nearby vein. So this is why using the ultrasound gives you the best possible chance to find a functioning lymphatics. And it's not just any ultrasound. There's a new modality called ultra-high frequency ultrasound. So this is ultrasound more than 22 megahertz. And usually you have to use at least 33 megahertz to find these kind of functioning lymphatics. With the classical ultrasound, it goes up to 18 megahertz. It is able to find in very healthy patients, but if the lymphatics are degenerated, it's very difficult to find. And this is why the new modality of ultra-high frequency ultrasound helps to find functioning lymphatics. Now this is a 70 megahertz lymphatics imaging device. Look at this. You could actually see valves in the functioning lymphatics. This is how powerful this mechanism is. So the higher frequency you go, the better fine resolution you have. And this is why using these ultra-high frequency ultrasound allows you to find the functioning and the largest possible lymphatics. And this is why it's one of the major innovations, at least to find functioning lymphatics. And what's interesting and exciting about this new field is that there's many new modalities that we're doing research. This is an example of laser tomography. Now we're using laser to detect ultrasound, and also we're using photoacoustic dynamic modality to map 3D imaging. So it's a really big revolution, and there's a lot of advancement in these fields. No, it's okay. So the second innovation is our ability to do, once we find a functioning lymphatics, now we're able to actually make a shunt of lymphatics to the vein anastomosis. So again, we're able to find it and able to do it. And this goes to the credit of Dr. Kushiba, because he developed the idea of doing small microsurgery, so-called super microsurgery under 0.8 millimeters. And also, a lot of the companies that we work together, like the microscope company, the device company, a lot of wound care company, and suture company, now allows us to actually manipulate these small vessels. So there's an advancement together with the industry. And I think this is why this kind of meeting is so important. As surgeons and as nurses, it is our job to know what kind of innovation is out there, so we can always help our patients. And what's really incredible is that not many people is comfortable doing these kind of 0.3 millimeter surgeries. So now we're having robots to do our microsurgery. So this is the latest innovation that I worked in the last 7 years. We're now able to have this kind of robotic microsurgery. And you can see how small the vessels are. And we're able to use this with a master slave like the Da Vinci, and ultimately have this kind of anastomosis. We've actually did the first preclinical trial, and it actually shows that it is a very intuitive approach. With only 4 trials, you're able to have a very clear understanding. So I think this video, shows everything. So here, this is me. You can see that very small, shaking a lot. And this is the robot, 0 shape. Same magnification, same size, around 0. This is the rat, by the way. So you can see the evolution in these kind of innovative approaches that allows now anybody can do these kind of solutions like lymphovenous anastomosis. Now the second, and as we do more lymphovenous anastomosis, there's a lot of more understanding that we make in this field. So a lot of people talk about the fate and how the lymphatics degenerate as the disease progresses. But not many people talk about actually how to find them, where to find them. So a lot of the functioning lymphatics are actually in the deeper fat. And now understanding this, we're able to do the surgery much more easier. So our target is functioning and large lymphatic vessels. And again, this is possible through the ultrasound. But not many people talk about what is the ideal vein. An ideal vein should be a vein with minimal pressure. Why? Because the LVA works with high pressure lymphatics to low pressure vein. So if the vein pressure is lower, then the shunting works better. So how do we find these kind of low pressure vein? That was the next question we had. So we have to think about how do we lower the vein pressure. And the first thing, especially in upper extremity, is when they remove the lymph nodes from the axilla, it causes a lot of scarring in the axillary vein. And this scarring increases the vein pressure. So now we know that by removing all the scar, we're able to dilate the axillary vein, we decrease the pressure, and the LVA actually functions much more better. So if there's an obstructive point in the vein, it's very important to remove it. And we published this work in PRS. So how do we also find vessels with less pressure? And we start to compare many modalities of the lymphatics, end to end, end to side. Side of the lymphatics to the end of the vein, and side to side. And in our hands, it works best by using the side of the lymphatics to the end of the vein. So why does this work better? Because in our minds, at least, we know that the lymphatics is draining from the proximal and the distal. And you can clearly see here, it's a statistical difference in the prognosis of the lymphedema. But also, by using the side of the vein, what important factor we must think is that we need to find a vein that has minimal pressure and no backflow. And that's what we start to do by finding these kind of ideal vein. And what's interesting is that if you find a vein that has a branch from the major vein, there's always a valve in the smaller vein branch. And when you have this valve, the vein does not have any backflow. So that's the key in finding the ideal vein, because no backflow means less pressure. So you could actually see that these smaller branches, if you use these smaller branches, the lymphatics is able to drain into the larger vein. But look what happens. When the small branch enters the larger branch, it sucks in because of the change in velocity. And this is called the Venturi effect. So using these small branches and utilizing this Venturi effect allows the lymphatics to drain much better with a statistical significant value, as you can see here, and this is also published in PRS. So this is how we identify ideal veins. Also, another good important tip is that we don't use patent blue or lymphozorum to map our lymphatics. In our hands, what we find is that the best dye to identify lymphatics is actually fluorescein. So fluorescein dyes are commonly used by ophthalmic surgeons. And when we do the dye, you can see that the lymphatics turns yellow. So it's very easy to see with the naked eye. But the innovation doesn't end there. When we paint the lymphatics with a blue pen. There's a clear contrast between yellow and blue. So what happens is, if we make a branch, if we make a side, you will clearly see the margins of the lymphatics, which makes it very, very easy to identify the margin and makes the anastomosis much easier. You see how clear it is? So it makes the anastomosis much easier. So we call this method the double contrast imaging to help identify the margin, which makes the anastomosis much easier. This is also published in PRS. So there's a lot of innovations that's happening. Now we know much more clearly how to find functional lymphatics, where to find large lymphatics, how to do the anastomosis easier, and what is the ideal vein. So now we're able to have these kind of evidence, which leads to working on more advanced lymphedema patients, and also trying to have a long-lasting result. Now, when you talk about result in lymphedema, we always say volume decrease 20%, volume decrease 10%. In my opinion, that is not the end point. From the patient's perspective, the most important thing the patient wants is, do I ever get off the compression? So now we've changed our endpoint to a point where we see if the patient is able to come off of compression. And the only way to do that is to have a good functioning lymphatics that is lasting result. So that has our change in endpoints. And now we're trying to have these kind of long results and help the patients avoid compression. The second anastomosis that I quickly want to talk to you about is lymph node to vein. So this is not supramicrosurgery. Now, if you look at lower extremity, most of the gynecological cancer removes the lymph node in the pelvic area. They do not remove the lymph node in the groin. So our idea was, okay, maybe we can use these groin lymph nodes to do a shunt. And this is exactly what we did. So we found functioning lymph nodes, and then ultimately used the superficial vein. And again, this idea is not completely new. There was a Polish group already in 1968 trying to do this, but back then, again, they did not have the technology to identify what is a functioning lymph node. So sometimes they open the node and it's not functioning, it's degenerated. However, now we have the ability to identify functioning lymph node and then basically connect and do the superficial vein anastomosis. So here's the superficial vein. Very easy, very large, almost 2 millimeters. Dissect, cut, and then with the ICG, we inject it in the foot. And what you see here, after you see the uptake of the lymph node. And when you see this, we know that this lymph node is clearly functioning. And when we see this, we make a hole, like we did with the lymphovenous anastomosis. And after you make a hole, you have to see lymphatic fluid coming out. So here, we penetrate with a 27 gauge needle. And after we penetrate, you must see the lymphatic fluid coming out. You see the white fluid coming out. So we know that the lymphatic fluid is clearly coming out. We anastomose the vein, and that's it. So this is not supramicrosurgery. It's regular microsurgery. You can even do it with loops. And then eventually create a shunt. And we call this the lymph node to vein anastomosis. And you don't necessarily have to do the distal leg. And this really works very well in a relatively early stage lymphedema. In the past, we used to identify with MRIs, but now we use ultra-high frequency ultrasound. So we were the first ones to actually say these are the 4 criteria to identify functioning lymph nodes. So with this criteria, we have 100% sensitivity, 100% specificity, whether the node is functional or not. So that, again, is an imaging, incredible imaging technology using our Fora advantage. So here's the pre-op. You don't see any node uptake. Post-op 1 year, what do we see? We see clear node uptake. So now we've recreated the function, recovered the function, and the patient is able to do his daily activities with less swelling. So this is a non-supramicrosurgery approach for the lymphedema. So you don't have to be a supramicrosurgeon. So that is the innovations that we made. And of course, there's a lot of innovations in the lymph node transfer as well, but we're not going to go into details. But now what we know is that all skin tissue have a lymphatic flow direction. So if you arrange the tissue in a way that the lymphatic flow is recovered, you could actually see patients with post-traumatic lymphedema actually improve without any LVA. So this is just recovering the fat-to-fat contact and allowing the lymphatics to regenerate in the subcutaneous fat. So we're having a lot of new ideas. And again, the third innovation is, we talked about preoperative imaging, we talked about intraoperative procedures with innovation, but again, a lot of the criticism that we had was, how do you measure whether or not this operation is successful or not? Especially in advanced stage lymphedema, they not only have fluid accumulation, but they also have fibrosis accumulation. So the tissue turns into a scar a lot of the times. And even if we do LVA, we don't know whether or not the fluid is actually improved. This is the limit of measuring the volume in advanced stage lymphedema. So now we use a technology called bioimpedance. This is a further modified technology, and now we're able to exactly measure the segment of the arm or the segment of the leg and actually show whether or not the fluid accumulation improved. So now we have targeted methods to see whether or not the LVA or the functional lymph node is working. And I think the biggest innovation overall is the approach of having a good team. Physiotherapists, nurses, imaging, the team, it has to be approached in a team. And also what we find out is that it's not only about one surgery, it's about multiple surgeries. Sometimes you have to do physiologic, sometimes you have to do non-physiologic. And there's a lot of the physical therapy involved. So I think the biggest innovation that we saw, again, in the fourth one, is our ability to understand the pathology and our ability to treat the patients according to the pathology with a good team. So nowadays, there is no one answer. It's not only about LVA, it's not only about lymph node transfer. These are the questions from the past. Now, the question needs to be, what does the patient want? Can we help them remove the garment? How much do they improve? What approach does this individual need? So nowadays, all our approach is based on individual needs and a more customized, combined approach. So these are the four major innovations that I just talked to you about in regards to lymphedema surgery. But, like I said, it's an exciting field. And because it's an exciting field, there's a lot of innovations that's going on. In the past, we did not know what the lymphatic system does. Lymphatic system is responsible for 20% of our body fluid. We did not know anything. So now, what's interesting is that we're trying to, now as you've seen before, now we're probably talking about solutions in chylothorax, solutions for protein-losing angiopathy, solutions for even venous ulcer by understanding the lymphatic pathway and providing a solution. But we're also doing a lot of research in terms of non-surgical approach. And this is where the shockwave comes in. The shockwave is used very commonly, and it's established with evidence that it works very well in diabetic foot ulcers. And the mechanism for that is that it creates angiogenesis by ultimately triggering triggering the increase in VEGF. So this is well documented. So when I saw this, I said, okay, lymphangiogenesis is also very closely related to VEGF. So maybe maybe we can find some evidence to see whether or not shockwave is effective for lymphedema treatment. And again, this is a very typical paper that was written by the American group and showing that shockwave actually heals much faster for diabetic ulcers when treated from 1 to 7 treatments alone is improving statistically. So we set up a model where we created a lymphedema using a rat tail, and we've actually tried to use multiple doses, 500 impulse, 1,500 impulse, 3,000 impulse, and 5,000 impulse. and whether or not there's an effect against lymphedema rat tail model. So the groupings did not show any formation. So all the formation volume was statistically same, as you can see here. And we started the treatment with the shockwave. And what was interesting is that initially, it all showed a good effect, as you can see here. But what's really interesting is that this is a major finding. The group with 500 and 1,500 impulse improves after the formation of lymphedema. Everybody improves in about 1 month. But look at this. The others with high dose actually recurs, including the control. And with 1,500 and 500 impulse, it has a long-lasting effect. Wow, that's very interesting. So we find out that this is not dosage dependent. So there's an ideal dose that has a more permanent effect to treat lymphedema. So why is this? And we did our histology, and actually in groups that have long-lasting results, we're able to see clear regeneration pattern of lymphatic vessels. So this is the LYV1 stain, which stains for the lymphatic vessels. And with the rat tail that's treated with 500 and 1,500 impulse, we're able to clearly see lymphatic regeneration, statistically more than the higher dose. And what's more interesting is that when we look at the H&E, the collagen pattern compared to the control, you can see that the collagen pattern becomes much more normalized in the rat group that we use 500 impulse. So in our minds, there's definitely a factor that is working with the shockwave in terms of lymphatic regeneration and in terms of recovering the normal collagen pattern of the tail. So our next modality is to start a clinical trial in the early stage lymphedema to see whether or not these patients can benefit without undergoing surgical treatment. In our hospital, all patients that have lymphedema actually goes through at least 6 weeks of physical therapy. And if the 6-week compression therapy fails, then they're referred for surgery. So during that 6 weeks, our plan is to use this kind of shockwave and see if we can reduce the rate of the patients that actually need surgical intervention. So I think this is a very important finding in terms of treating early acute lymphedema patients. And finally, what is really most exciting about doing lymphedema disease, lymphedema surgery, is the possibility for dementia. And I think a lot of the plastic surgeons already know this. In 2012, we finally find out that the brain has lymphatic system. In 2017, we find out that because of the failure in the lymphatic system in the brain, the metabolites like beta amyloid increases and causes dementia. So now we're at a phase, we're searching to find a solution by doing LVA on the neck to improve dementia conditions. And it's exciting because we just finished a preclinical trial using the ultra-high frequency ultrasound, and actually we're able to identify degenerative lymphatics in the neck. So maybe this hypothesis is true. It's exciting. It's an ongoing field. A lot of the results that we see now are preliminary findings. And there's still a lot of evolution, not only in our skills, not only in knowing the knowledge, but also advancement in technology with the industry. And this is why it's very important that we work closer together as a team with industry and academics, and ultimately find solutions for this very debilitating disease. So for those who are interested, we have the lymphedema workshop as well in October. And once again, I'd like to thank my brother, Yuren, for the invitation. And thank you all, and hopefully we'll get to know each other more. And finally, I want to say thank you to Andy, who's sponsored my visit. So with that, there's a DermaPace booth, so if you want to go take a look, I think you'll be able to play with it. So, 谢谢.
Thanks, Professor J.P. Hong. That's the very inspired talk and also new innovation. research. I wonder, do you sleep? How you can contribute so many ideas in this sleep?
Huh?
I don't have time to sleep. But
Well, I hope that I have time to sleep because now we know by understanding the lymphatics in the brain clears the metabolites during sleep. So nowadays I try to sleep at least 8 hours. And if I drink a lot, maybe I'm lucky to sleep 10 hours. So maybe alcohol is a solution to dementia. I don't know, I'm just thinking.
any question on the floor? Yeah.
JB, thank you very much for your wonderful lecture. I just have one question, want to ask your opinion. How about the prophylactic lymphedema treatment for breast cancer therapy or the GYN cancer? Thank you.
Yeah, this is a very important topic as well. And I'm sorry that I didn't have time to cover everything. This talk is actually a 3-hour talk. And if I did 3 hours, you will probably kill me. Because I'm causing too much delay. So the question is, what is the current understanding of preventive LVA? So preventive LVA is once you remove the lymph node, for example, in breast cancer, you remove the lymph node in the axilla. And when you remove the lymph node in the axilla, you do immediate lymphovenous bypass in the axilla. So that's the concept of preventive LVA. If you look at one of the reports that were out from Columbia last year, I think it was June, they actually showed that the 5-year follow-up of doing preventive lymphedema and not doing anything had no statistical difference in the formation of lymphedema. Now, I think that study was wrong because that study covered all patients. And my hypothesis is that there are patients with high risk for lymphedema, and preventive LVA should be focused on finding those high risk. For example, in our hospital, we do 3,800 breast cancers a year. I cannot do 3,800 LVAs. I would need 10 more people to do it. But if you think about it, only 20% of that 80% of that patients has lymphedema. And in that 20% that has lymphedema, only 20% will require surgical treatment. 80% of these lymphedema patients gets better just with compression. So how do we identify the patients that are risk for surgical solution? So far we have identified 3 major risk factors: obesity, radiation, and what was the third one? Oh, and patients that develop lymphedema after 6 months. So the third, we don't know. But if the patient's obese, if the patient is scheduled for radiation, these are the patients that we try preventive LVA, and we have a new study going on just by doing high-risk patients. There's also a study in MSK that's going on just for high-risk patients. So I think we'll know more whether or not this is effective in patients that have high-risk lymphedema. But with the current data, it's very difficult to tell. But my assumption is that if we do it for high risk, it will help these patients very much. That being said, we've actually almost finished a clinical trial for gynecologic cancer. And for gynecologic cancer, we identified a high-risk patient group. So in gynecologic cancer, if you remove more than 80% of the lymph node in the pelvic cavity, the lymphedema incidence in 6 months is 50%. In 12 months, it's almost 80%. So these patients will have lymphedema 80% of the time. So we did LNVA, lymph node to vein, in 70 patients. And believe it or not, 6 months, 1 patient, transient lymphedema. 12 months, 0 patient. It's incredible. So I don't know. So I think for the high risk, we've identified that it works in the lower extremity, but we'll find more information for the upper extremity. Yeah. Thank you.
We have a question. Today, our society mostly is the wound care specialist. So, mostly more difficult is for the venous ulcer. And some literature has mentioned use the LVA could improve the venous ulcer. So how about you today? Your talk is that LVA approach also has such evidence to improve wound healing or combination with the shockwave treatment also much better. How's your perspective?
Yeah, so with shockwave, venous ulcer is shown to be effective, and it's been documented multiple times. In regards to LVA, when I saw the literature saying, maybe LVA works for venous ulcer, I said, no, that's bullshit. But think about it. In venous ulcer, the main modality of treatment is compression. So why venous ulcer affects the compression? We don't know, but we know that compression works. And sometimes patients with venous ulcer, they don't always have venous problems. So I do believe that there is a segment of the lymphatic pathology in venous ulcer as well. And now I'm starting to believe that maybe LVA also has a role for venous ulcer. So I think we need more evidence, but I don't have evidence personally. I have limited surgical experience, but now I'm starting to think maybe it is one of the possible solutions, because we know that shockwave works. So shockwave is closely related to formation of lymphangiogenesis. So maybe LVA also works. So I think once we see more data, we'll be able to know. And this is why it's exciting, because we don't know what is lymphatic disease and what is not lymphatic disease. So, and this is why it's exciting, and there's a lot of possibilities in this field. So I think it's very difficult to say what works, what not works, but we have to have an open mind. And as surgeons and as medical care professionals, our job is to find evidence. And when somebody presents something, scrutinize and support to find evidence. That's our job. It's not to say it doesn't work, it works. Our job is to find evidence.
Thanks. Any question?
Thank you, Professor. Your wonderful talk. My question is about you use a red tail model to evaluate the effect of dermatitis on lymphangiogenesis. And the first question is, if you check the VGFC expression after treatment, because I saw you only show the LYV1 expression.
Yeah.
And the second question is, for the red tail model, it's actually not the same with the human lymphedema, because most of are from the lymph node dissection. So it is more like a wound healing model, and during wound healing, actually there's angiogenesis, and it may be associated with the finally lymphangiogenesis. So how is your idea about this? Thank you.
Yeah, this is a very good question, and I'm sorry I didn't have enough time. I tried to cut all the slides to keep 40 minutes. We did CD31 expression to see the angiogenesis factor, and in the 500 and 1500 pulses, they did have a statistical increase in CD31. So we know that there's an increased expression for angiogenesis, which we think is VEGF. We did not do any marker studies for VEGF separately, because this is already established. And this is why we did CD31. So we think indirectly that this is the effect. Now, regarding your question on how do we know this works or not, in the rat limb model, the rat lymphedema model, if you look at the control, it continues to grow. And if you look at the high dosage model, the volume also continues to increase. So even if we know that the rat healing model is always quick, most everything heals, then it should have a plateau. But in the lymphedema model, the volume increases up to 3 months. And this is why we think that this is a valid model. If the rat is healed, then the control should also have a plateau at some time and go down. But this is not what happened in the rat tail lymphedema model. So we think It's a lymphedema model. It's not a healing model. So I hope I answered your question. And again, based on this, now we're excited to go to clinical trials. Yeah. Sharp question. Thank you. You deserve a beer. With me.
Have any other question? Yeah.
Hi, JB. I enjoy your talk very much. I'm interested about dementia because I'm getting older.
We all are.
Do you think lymphedema play a pathology for dementia? It's intracranial or extracranial? So you take the extracranial procedure to resolve the dementia. Is that reasonable?
Yeah, this is a very good question, and I could talk 1 hour on this question alone. So to answer your second part first, the dementia pathology is a result of metabolic accumulation of beta amyloid in the brain. So it is intracranial. So the question is, how do we enhance the clearance? And what we find out is that in the brain there's two lymphatics, the G lymphatic system and the meningeal lymphatic system. The G meningeal lymphatic system works to push the metabolic substances toward the meningeal lymphatic system. The meningeal lymphatic system gathers it and then clears it through the jugular foramen into the cervical lymphatics. So that's one pathway. The second pathway is through the cribriform plate in the nose and then also clears to the cervical lymphatics. There's a recent article, and this is exactly the article that answers your question. How do we know then what happens to the lymphatics? Because a lot of the criticism that I have is, oh, you know what? We removed a lymph node in head and neck cancer, and there's no increased incidence of dementia. Why? That was one of the biggest criticisms. And now we find out that in the nasal, along just above the cribriform plate, there is a special type of lymphatics that actually undergo degeneration with aging. And that's what accumulates the lymphatics. And even though they think, it's not my idea, they think, even though the jugular foramen lymphatics is functioning, because of the anterior nasal pathway is obstructed, they think that this is not enough to clear, because they have two pathways, one pathway is gone, only one pathway is not enough. And this is why I think if we're able to enhance the clearance capacity of the one that's coming out from the jugular foramen, then I think it may help with dementia. So there's a very good article in Nature just about this talk. And I always have the same question. And now I think we have more answers. So it's a very exciting field, and there's so much to learn. Yeah, my neurologist thinks the same. It's bullshit, but I don't think it's bullshit. I mean, we all, as gentlemen, that we all have dementia sometime. This is why in our life the wife is always the boss. Because the boss has to take care of me when I have dementia. But now, who knows, huh? Hey, I hope nobody's recording this. Edit, okay?
Yeah, I think that's a work you need to put in, and in the beginning we think that's ridiculous. That's true, as JP mentioned, bullshit. But that's the that now has some new finding. I think will be another new field to investigate. Due to time limit, we need to close today this morning session. And so the society wants certificate to thanks Professor J.B. Hong's so inspired talk, and thanks your contribution. And I hope you will come soon and give us more lecture and share your experience. Thank you so much.
Thank you.